What you gotta do is move direction. You gotta try to be straight. Yeah. So I didn't want.
Good afternoon, everybody. Appreciate your dedication for showing up for the final episode of today's presentations. Thank you for being here. I'm going to turn it right over to Ms. Gainer, and she's going to talk about the opioid use and correctional centers.
Thank you. Good afternoon, everyone. Good evening, right? Because it's close to the evening. I'm going to try to get you all out of here at 4:30. My name is Rabia Gaynor. I am the Associate Commissioner of Criminal Justice at New York State Office of Addiction Services and Supports. Oh my goodness, the chairman's here too. Oh my gosh. I'm here, thank you all for coming, especially this late day. I'm here to talk about medication, providing medication for opioid use disorder in carceral settings, but it leads out into even the community, parole supervision, community supervision, probation, and just people in general that are not incarcerated, right? So I want to just go over everything with you, but before we go through the PowerPoint, I just want to ask you one question, right? And stand up if this applies to you. Well, no, I'm going to say, no, you're seated. So what I'll say is, I think everyone in the room, has anybody heard of harm reduction? Okay. Everyone in the room is a harm reductionist, I'm positive. To what level that may vary, but I believe you're a harm reductionist. Does anybody believe that they're not a harm reductionist? Please stand up. Everybody believes they are? Okay, all right. This is the first. Because I've been in rooms with people where they say, no, I don't believe in it, but it's a proven fact that we all are. So I'll give you an example, just for regular knowledge. Wearing a seatbelt when you're driving, that's harm reduction, right? Brushing your teeth so you don't get tooth decay and lose your teeth, that's harm reduction. And so harm reduction comes in different forms. And when it comes to medication for opioid use disorder, it has to do with providing Narcan if someone needs it to be revived, giving them medication if they need it, referring them to counseling and so on. The division of today's agenda, the OASIS Division of Criminal Justice, the role of medication for opioid use disorder. I'm going to talk about the law and some comment minutes, and then give you a chance at the end to ask questions. The OASIS Division of Criminal Justice. Why does OASIS have a criminal justice division? Right? That's to me, that was something that I wondered before I got there. OASIS system overview, right? So just so you know a little bit about this agency. We're an agency about maybe 1,000 people. We're not as large as other agencies that have tens of thousands, but we have about 1,000 employees. We oversee 1,700 prevention treatment, harm reduction and recovery programs. We serve between 730,000 to 750,000 individuals per year. We own and operate 12 addiction treatment centers throughout New York State, and those are employees of OASIS. And this is where people can come up to 90 days, sometimes a little longer, up until 4 or 5 months. We also want to mitigate harms of substance use and prevent overdose deaths in carceral settings, but we also want to prevent that in the community as well. We facilitate transitions to substance use disorder treatment programs in the community as well. Okay, so OASIS has a continuum of services. So you have prevention before you even get to substances, right? We try to catch people before. But if you happen to get involved with substances and it becomes a problem, we have treatment. We have harm reduction, and then we have recovery. For prevention, there's a lot going on in schools, and community coalitions, parent and family programs. We screen and do brief interventions and referrals. We have public awareness campaigns, cannabis toolkits, and drug deactivation toolkits. For treatment, we have crisis services, inpatient services, residential, which you're all probably familiar with, outpatient treatment programs, opioid treatment programs, gambling services, and we have treatment in all facilities, so all 44 of the docks facilities, prison facilities, correctional facilities, and we have them in all of the county jails. Harm reduction, right? Harm reduction, I talked about that at the beginning. Naloxone, we have training, we have testing strips. It sounds weird, but to be honest, if someone's gonna use substances, why not offer them a testing strip to see if fentanyl's in it, right? They might wanna party safely, believe it or not. And if they have fentanyl in it, they might say no, and that can save their lives. We have overdose prevention, public awareness, anti-stigma. You might have seen the signage, the commercials at the Super Bowl. Last year, we had an Oasis commercial running, outreach and engagement services, and low threshold treatment. For recovery, we have peer support. That's the big thing, peers in courts. We're trying to get more peers in courts, especially the overdose intervention courts, but there are some peers now, and we're trying to increase that. We have recovery residences and housing supports, recovery communities, outreach centers, youth clubhouses, because we care about the young people too, and also self-help. This is my team, that's me. I have Ellen Tryon, who retired from the SCLC. She's amazing, so she's the new director. That's the executive assistant that handles just coordination for us all. And then I have the two people that deal with jails, prisons, and the courts, so this needs to be updated. The role of medication for opioid use disorder. High overdose risk post-release, right? So people might not care about people like saying, okay, they're out of my jail, it doesn't matter, or they're out of my prison. It's very important that we make the proper linkages to discharge planning so that when people come out, they may be on community supervision. They may have done short jail terms and been released on probation or never, something to that effect. Or they may have just been released to the community. And you want to make sure that they have linkages. It's very important. So that to me is important for community supervision, Department of Corrections. And community supervision is important to probation. And it's important to the jails to make sure that they make the connections. Overdose is the leading cause of death among people released from jail. They lose the tolerance. They lose the tolerance, they come out, they use, and they think they can use the way they did before, and they die, right? And so that's the truth. That's why it's important that they're medicated properly while they're there. Unintentional drug overdose study. You can also make take your camera out, and it'll open up the addiction data bulletin for you. But 90 days after substance use disorder treatment is a high overdose death risk, especially the first 14 days. As I said, they lose the tolerance, they come out, they party with people or just by themselves, and they can die. So we try to do the enhanced timely treatment plan. We promote retention, we ensure safe treatment transitions, and we integrate harm reduction across the SUD treatment. Why MOUD in carceral settings? Involuntary withdrawal MOUD. Some county jails have told me, oh, we're gonna just have them, withdraw. We don't have to worry about medication. That's not really fair. That's not really accurate according to the law. According to the law, we have to make the three approved FDA medications available to them. And if they want to have medical withdrawal, then we have to do it properly and we have to get their permission. But we can't deny the medication and say that's what we're doing. You have an increased risk of death at that way. Treatment of opioid use disorder. It's a chronic disease. It's a public health condition, right? There's no cure for it. It requires a lifelong management and behavior change. Some people can be abstinent. Some people cannot. And if they cannot and they need help with medication, then we should make that available in the community as well. There's behavioral treatment, medication, opioid agonists, which is buprenorphine and methadone. And then you have the opioid antagonist, which is naltrexone. Types of medication for opioid use disorders. You have methadone, you have buprenorphine, and you have naltrexone. I will say this, from my experience, I don't always find buprenorphine readily available in certain communities, and I'll say communities of color. And that's the most discreet way to get your medication. You go and get your prescription for the pharmacy. The methadone is a little less discreet, but it's also, available, and then naltrexone is also discreet. So I'm working to see in the community that everybody has access to all three forms. But in carceral settings, all three forms are available. Who should be considered for treatment? Anyone with symptoms of opioid withdrawal, anyone with a diagnosis of opioid use disorder in any severity, and even if you have a history, even with no recent use. So if somebody enters a carceral setting and they say they used to use and they want to be put on, some of the providers will say, no, but you've been not using. But the bottom line is there's temptations, there's triggers, and if they need to be put on it to safeguard, it's supposed to happen for them. Buprenorphine and methadone effectiveness. It eliminates opioid withdrawal symptoms. It normalizes brain anatomy and physiology. It decreases cravings, and it decreases HIV and viral hepatitis. Decreases all cause and overdose-related mortality up to 59%, and that's a big deal. Improve outcomes through correction-based MOUT programs. So how does this help someone who's a correction officer, right? How does this even help someone who's a parole officer or probation officer? One, when you have people on medication for opioid use disorder, their behavior is improved. During incarceration, more stable mental health behavior for incarcerated individuals, fewer disciplinary tickets, reduced withdrawal symptoms and distress, calmer, quieter environment for the staff, fewer safety and violence issues, increased job satisfaction, and understanding of substance use disorder. I will say I was a correction officer, I was a parole officer, and I was a probation officer. In the carceral setting, it does help, right? It helps because you don't have people trying to, well, no, I won't say this. You still have people trying to smuggle drugs into the facility, but you have more people that have access to the medication and won't require that. And they'll be stabilized. Better post-release outcomes. Healthcare cost savings, reduce crime and recidivism, right? Because they're not coming out to get high and rob anybody and commit new crimes. They more so are going to see their doctors, getting the medication. Costs for incarcerated individuals receiving MOUD post-release were half that of others. Why this is important is the law, right? It's the law. The law was written October 7, 2021. It went into effect. October 7, 2021. It went into effect October 7, 22. Expanded medication for substance use disorder in prisons and jails. The state law that went into effect October 7, 22 requires that the medication be in all the facilities, peer support, discharge planning, counseling, individual and group counseling. All 44 of the dock state prisons have medication for opioid use disorder, and they're doing well. This is the largest implementation of medication for opioid use disorder in a carceral setting in the U.S., New York State. We're leading the way, believe it or not. Support, right? So these are some of the people that gave support. The National Sheriff's Association, they gave support, they continue to give support. American Correctional Association, National Commission on Correctional Health Care, and the National, the same. One jail's implementation experience. I didn't want to call that jail out, but it's in the area, I say that. The sheriff experienced resistance among the correction officers when the MAC program first started. The start of the implementation required correction officers to sit in on case conferences and participate. Correctional officers saw calmer incarcerated individuals, not sedated, not high. Better participation in post-social activities. Correction officers began to support medication for opioid use disorder. They had to see it to believe it, and I understand that, but they started to. And now the county that this is referring to is doing exceptionally well. Multi-agency collaboration. So OASIS can't do this without without these agencies and the programs. So DOCS is very important. They're leading the way. SCOC, they're the oversight, right? So they help, they audit, they help, they provide guidance, they create policy. OASIS monitors substance use disorder programming with DOCS in the correctional facilities. And then we also monitor the county jails. And the SCOC leads the way and helps us with that. Jails receive OASIS state funding to support, right? So that's important because when you're implementing law and you have to do something new, you need money. So we give a lot of money and we get ready to give more money for medications. We just finished doing a round of 58 county jail interviews, myself and colleagues, and we want to give more money towards medication. We already give jail-based funding. There's also opioid settlement funding that's going, also AG's office opioid settlement funding. So we work with the local government units to make sure that this funding is going to the jails and they use it in the appropriate way. Timeline of implementation. So early implementation, October 7th. At that time, a lot of people didn't have access to opioid treatment programs, so we gave waivers at OASIS. Since then, we worked with connecting people with opioid treatment programs. They opened up, they ended up being closer. We gave the opioid treatment programs money to help the jails. So now everyone's connected, all of the county jails, all over New York State are connected to opioid treatment programs. DOCS already was connected to opioid treatment programs. They have contracts going. We give money towards that, and that's running well. Goals of the new law in carceral settings. What are the outcomes? Initiation of MOUD among those who need treatment. It needs to be at intake and during incarceration. Within the first 24 to 48 hours, screening should be done. Screening should be done because if you have to put someone on medication, they need to get on it. They should not be waiting 10 to 14 days. They will withdraw and they may die by then. Or they may try to get someone to smuggle drugs in. Continuation of MOUD from the community at intake, and then when they leave, they should be referred and connected. Release on MOUD to the community at intake post-release. So why do you think somebody at intake needs to know about getting out? They might be bailed out. The case might get dismissed quickly. They need to know where they can go to get connected to services even if they don't get the full discharge plan done. Implementation in New York State DOCS facilities. So DOCS went over these statistics with me and they let me know that this was just a snapshot as of July 1st of these respective years. So this tells you like what's going on in DOCS, you know, a snapshot as of that date, what was going on. And you see that they have a substantial amount of people who are on the MAP program. And you can see everything that's going on. So they have continuation at intake. That means somebody came in and said, I'm already on MAP, so they continued them. You have somebody that was not on it but may need it, right? So then they initiate them or induce them. And then you have methadone. People might be on medication, for methadone medication. You connect them to the OTP right away and get them to methadone. And these were the program participants. Okay, so this is saying implementation NYS, SCOC facilities. That means the county jails, all the county jails. That's separate from the DOCS correctional facilities. So this is the number reported for OUD screening for 22, 20, and 2023. And the numbers have significantly increased. MOUD program participants, again, significant increase. Release with transition plan in place, significant increase. So it's good to know that, I mean, it's not good to know more people are having to be on the program, but it is what it is. But it's good to know that they're getting access to services. So this is a big one. I always get calls and emails about diversion. When I call sheriffs and county jails, they always complain to me, I'm sick of this MAP program. You know, they're hoarding the medication. You know, it's causing me a problem. And my response is this, because I came from New York City Department of Correction, and I dealt with the death investigations, and I dealt with the overdose. Would you rather have the medication available and get people connected to treatment, or would you rather not force them to withdraw, they either die in their cell, you hit the papers, or, people start questioning you, or they start getting people to bring in drugs in your jail, right? And more people are getting high off illicit substances. It's just better to get them the treatment. It's a health condition. I always say to the sheriffs, if somebody came in with hypertension or diabetes, would you make them wait till they got out to get medication? Because that's what they tell me, they can get it when they get out. Would you do that if someone had diabetes or hypertension or a heart condition, right? And so you wouldn't. But people choose to do that with people who use substances. You shouldn't. It's a chronic health medical condition. After a while you use it, it changes your wiring in your brain. It's medical at that point. It's not just share, don't pick up. It's not that easy. So how do you address diversion of medication? Identify and address root causes of diversion. What's going on? Are you giving them access to medication? Is their dosage too low? Send them back to the clinic. Tell them to talk to the doctor if you find that they're diverting, trying to hoard medication or exchange it. Expand screening and access. Make sure you screen everyone that walks through. Even if you don't think they look like they use substances. Screen them. You'll find out. Utilize the disciplinary system. You can do that. So I'm not saying you don't put them in solitary confinement, but you can give them a ticket, right? If they're doing that, but you don't take them off the medication because it's medication they need. If somebody's doing something wrong, you don't say you're not going to get your diabetic medication, so you shouldn't do it with this as well, but you can discipline. Assign dedicated staff to the MOUD program. I found this most effective for New York City Department of Correction, that when you had staff that worked with the same population, the same housing areas, everybody got used to them, they knew people's habits, and it worked well. Now I know with shortness of staff, sometimes that can't happen, and you have to get who you can get, that's fine, but then maybe you need to expand your training and awareness to all staff. Encourage multidisciplinary team communication. That's very important to me. When you are in a facility where you have the MAP program, the uniformed staff must work with the civilian medical staff. It's very important that they communicate. It's not one against the other. They have to communicate. They have to talk. They have to have understanding of what needs to happen to make the program work within the carceral setting. So when you have meetings with the health staff, have your steady officers there. Have your warden or your sheriff or your deputy warden or your superintendent of programs, have somebody there to participate in that meeting so that they know what's going on and provide training, ongoing training. I think the training needs to happen for the uniform and non-uniform staff. Common myths about medication for opioid use disorder. Myth 1. Medication for OUD is just trading one addiction for another. How many times have you heard that? I hear it, oh, it's just putting them on another drug. It's not the same. And then I hear about, oh, it's the side effects. How many people take medication where they list side effects? Almost every medication has side effects, right? Even Ozempic that everybody was on, side effects, but people take it, right? So, that's really, you have to see if it works. Medication for opioid use disorder is just trading one addiction for the other. That's not true. People who are addicted to opioids are agitated and chaotic. People who use medication to treat their addiction are calmer. Methadone and buprenorphine stabilizes OUD symptoms, allowing a return to usual functioning. So people could actually get on MOUD and work and have normal lives. OUD, opioid use disorder, is characterized by compulsive use and associated behaviors that can lead to dysfunction in their lives. Myth 2, MOUD should only be used short term. Well, that's not true. Longer treatment with MOUD is associated with better outcomes compared to tapering. But some people can return to abstinence, so I don't leave it out. Like, to me, and I know the courts promote this, abstinence, that's key, right? That should be number one. I agree. But until they get there, then provide treatment, right? Until they can get there. MOUD should continue as long as the individual benefits from treatment. Myth number 3. MOUD is not for those who have stopped using opioids or are no longer in withdrawal. That's not really true either. It sounds true, but it's not. Anyone with a history of OUD is eligible for treatment. So if a person's saying, I'm feeling triggered in this carceral setting, or I just got out of prison, I'm feeling triggered, give them the OUD if they meet the criteria. Because maybe coming home from a long prison stunt has them nervous, has anxiety, right? So give them something to keep them stabilized. Myth number 4, MOUD increases risk of overdose. You don't get high off the medication, that's one. Methadone and buprenorphine OUD treatment is associated with a plus 50% decrease in overdose death, right? So that's a good amount that, give it to them, 50%, the people will be alive. Myth number 5, there's no proof that MOUD is better than abstinence. MOUD is evidence-based and is the first line treatment. Non-MOUD treatments provide no protection against fatal opioid overdose. This should be the last myth. Lower doses of buprenorphine methadone are effective as higher doses. That's not true, right? So I've had providers tell me that. And they sometimes say, I'm only giving them 4 milligrams. Depends how much they use in the community. The dose, it shouldn't say inmate, I'm sorry. A dose that an incarcerated individual needs depends on how much they've been using. The more someone has been using, the higher dose they need, at least at the start. Lower buprenorphine methadone doses thought to prevent misuse have never been proven clinically. Higher doses may control cravings, prevent return to use more effectively than a low dose. Again, based on how a person's been using. Evidence shows methadone doses and buprenorphine doses associated with better outcomes, right? So 80 milligrams and 16 milligrams. And when I hear from some of the county jails, they say 4 or 8. The doctors tell me. And I then call my chief of addiction medicine and have Dr. Munn call them and talk to them, because sometimes people require 16 milligrams. Okay, so that ends it for me. That's my contact information. I just will give you a little background about myself. I should have done this at the beginning. I have 14 years plus of law enforcement experience, so my heart is with law enforcement, right? That's my heart. But I also have 8 years of correctional health experience and executive leadership experience. And so that's the other part of my heart, where I care about people's health. I did not like going to death investigations for overdose deaths. I went to so many in the 7 years that I worked for the New York City Department of Correction, and it could have been avoided, right? It could have been avoided because diversion. People were diverting, people weren't paying attention. It could have been diverted, it could have been avoided if the doctors gave proper, adequate medication for opioid use, and the person didn't think they could try to go get high and continue. And so I just don't want to see people die in carceral settings. I don't want to see people die out, and I want them referred to proper discharge planning upon release so that the community can survive. Most people think of people that use substances as people that are laid out on benches, right, or on the ground, right? I have a 14-year-old, that's what he thought, and I had to educate him. There are people that are working that have opioid use disorder, right? They look like me or you. How many people have to go home and take a drink to relax? That happens, right? And sometimes the drinks get more and more and more. That's regular people. So everyone that deals with substances or uses substances deserve to be treated with dignity, whether they're laying on the ground or whether they're not, and they're working right next to you. They need to be treated with dignity and respect, and we need to just change our words. Instead of saying drug addict, person who uses substances or has a substance use disorder. You know, it's very important that we do that, because many people are in recovery. And so, because I don't use substances doesn't mean other people don't, and doesn't mean I shouldn't have compassion and understanding about what they do. And people use substances, people smoke cigarettes, people drink alcohol, right, which is illegal, but people use other substances. So it's very important that we just are mindful when we're dealing with people, and the same people that incarcerate eventually come home to one of your communities. They don't live in space, right? When they come out, they live somewhere. And so we have to be mindful of that. And you want to welcome them back in a better place than they were when they got to where they did. That's it for me. Thank you all. Anybody have any questions? Yes, sir.
So you spoke about methadone quite a bit.
Yes.
And I know you mentioned that docs specifically would continue methadone
Yes.
in the correctional facility.
Yes.
jail specifically, is methadone the main medication that's used there?
So in the county jails, you have all three forms. The two main forms are one methadone, but also buprenorphine, and that can come in the form of injectable. It can come in the form of films that you put in your mouth or tablets.
And I know, so.
And some naltrexone, some use that.
Okay, and I know that docs is always just continuing the methadone, they never put anybody else on it unless they reach.
No, that's not true. They initiate people, they have people initiated. They're connected to the OTPs, they have relationships and memorandums of understandings with the opioid treatment programs, and they work it out where someone can be initiated if that's what they choose. Docs tends to use Sublocade only, a lot more, only because it stops diversion, and they have to be concerned with that, right? So I have to be understanding of that. But they also have their contracts with methadone OTP programs, and they do utilize them. And they're working out well with them. Docs sends officers and a nurse to go pick up the medications. They bring them back to the carceral setting, 7 to 14 days at a time, depending on the correctional facility, and they make sure that the person gets the doses.
So, to be clear, if somebody comes from a jail and they haven't been on anything prior, in the jail, and they come to a docs facility, correctional facility.
Yes,
They can elect to go on methadone, and docs will start them on methadone.
if they meet the criteria, they will screen them,
Okay.
right? They will screen them, ask them a series of questions, do a physical, and they can be placed on it, yes.
Gotcha, okay, thank you.
You're welcome. They have their whole MAP program, and they started their MAP program before the law, but they perfected it since the law, but they've been doing very well.
So then, just for clarification, how long is the program, does it last? Is it indefinite, or is there a time frame where you wean them off the medication?
It's supposed to be indefinite, as long as you need it. It's supposed, like, you might need lifetime medication for opioid use disorder, you might not, right? If you choose to not be in a program, they don't force you to be, but you can be on it during your whole length of incarceration, no matter where you are. But if you choose not to be, you don't have to be. Yes.
Are there people who max out who have been involved in the program? Is there any special referrals for them if they're maxing out?
So you mean in carceral settings?
Right, and they're not gonna be on parole.
Okay.
Just maxing
Oh,
out.
yeah, so for them, they get discharge planning too.
Yeah.
They get discharge planning to, you know, wherever's in their area, right, for whatever medication they need or counseling, whatever have you. And they go as long as they go. The programs, I mean, people want to get paid, right? So we're hoping they get connected with insurance, Medicaid, or some type of insurance, but they're allowed to go. They're back in the community, and as everyone else, they go as long as they need to go. They don't like say, oh, you only can come for 6 months. That's residential, but a regular outpatient, you can continue to go ongoing.
It would still be part of their discharge planning.
Yeah. Yeah, and some people require high level care, residential, right, and then they eventually go down level to outpatient, but a lot of people don't require a high level care, especially if they've been stabilized in prison, in carceral settings, jail or prison. They can come out and go to a community, and they don't have to go all the time. You can go get your medication and not go to counseling if you don't want to. You know, it's just about being stabilized, keeping the wiring in your brain stabilized. Yes, sir.
How much difficulty have you seen with the buprenorphine? I know that there was like some shortages and stuff in the past. Are you guys still kind of seeing that trend continue as?
Shortages where? Carceral settings or community?
I guess both.
So community, there shouldn't be a shortage. We have the low threshold program throughout New York State where you can go to Matters. It used to be called New York Matters, but it's called Matters. You can get a hold of buprenorphine. There's not a shortage of medication, it's just if you have the money to pay. So the carceral settings, the county jails, that's why we're looking to give them increased money, because we realize they're struggling a little bit with the Sublocade injectable, because that costs more than the film or the pills. But as long as you have money to pay for the medications, you can get it. There's not a shortage of supply.
Gotcha.
So the jails have been doing okay so far, but OSS is looking by January to give them additional money to make sure that they can use the money that we give them just for the medication, and then reallocate the other money toward discharge planning or peer support or counseling in the carceral settings. You're welcome. Anyone else?
I guess the carceral settings, when you're discharge plan, would you maybe shift them from, say, methadone, which is a daily dose, to say naltrexone or something?
It depends, they might.
Like a bridge from that drug activity.
Yeah, they might. Like some providers, I have now going since September 11th, for the medical providers, I have a work group going. I have all medical directors. I have Dr. Sharon Stancliffe from New York State DOH. I have Dr. Pamela Munn, the addiction chief for OASIS. I have Dr. William Vale from New York City, H&H, Correctional Health Services. And I have the Dr. Michael Falk from Chautauqua, right? So this is a work group I created for them to help people. So one of the questions that came up was if someone's been on methadone, but they get ready to be released and they don't want to have to deal with the methadone program when they get out, right? They don't want people to know in their community they do it. Can they be switched to buprenorphine? The answer was yes. So they work that out with them if they know a discharge date, and they work it out to switch them on buprenorphine. So you can switch if you want to. Some people say other things work better than others, so it just depends between the patient and the provider. Anyone? Yes.
Just more of a comment. I'm an investigator with the Enforcement Administration, so we do the audits and inspections of these OCPs. And I remember one time in particular, we asked them what their patient group was, the patient rate, and they said they had an 88-year-old patient, and he's been coming, and they tried to get off it at one point, but ended up relapsing because he just didn't know what to do with his time. So it's not necessarily that he needed it for medical reasons, but it's just like he didn't have a place to go in retirement, per se, and that was like kind of his.
And that was his coping mechanism to use substances. Yeah, some people do that, right? And so it's a struggle. And so that's why I say everybody cannot be abstinent. Some people can. So that always should be your goal. But if you can't, then take the treatment, right? It's just like everybody should be able to lose weight, right? Sometimes you can't. I'm an example. So some people use things to help them, right? It's not a bad thing, it's available. So we're grateful for those other things. But it's the same thing with the medication, right? You be grateful that there's medication out there that can help them reduce the cravings or eliminate the cravings, and see where they go from there. Maybe they can titrate him down, right? That's something maybe they didn't do for that 88-year-old gentleman. But maybe that's something they could do. Lower it, lower it and see how he functions. But that's a good example that sometimes people are just not there yet. Or they're there, but it just didn't happen at that moment. Also, just to know, when people get released, they're required to get released with 7 days of walking meds, and that includes methadone or buprenorphine. And that's important, just to give them time to get to the doctor or the methadone clinic so that they don't go out there and overdose, especially if they got released on a Friday. It's, you don't want them to. Yes.
Just one more follow-up question.
Yes.
To the treatment plan or program, and dealing with the coping skills. Are you implementing any coping skills outside of the medication?
Yeah, it is supposed to get, the law requires 4 things. It requires access to the 3 forms of medication, right, FDA approved, peer support within the setting, counseling, individual and group to help cope and understand triggers and what led to this, right, the root causes, and then discharge planning, last but not least. So make sure they're connected to ongoing services when they leave. Such as a program where they can get counseling, a doctor where they can get their buprenorphine prescription, or a methadone clinic where they can get buprenorphine or methadone. To make sure, and then also housing, right? Housing's a big deal. When people are homeless, you think they care about treatment? They don't. They don't, right? They're not sitting on the ground saying, oh, I'm gonna just get, no. So also coordinate housing for people. That's very important. That's very important. To the best of their ability. Sometimes it ends up a shelter, but other times they can get into transitional housing. Sometimes they have family and so on. But yeah, they are referred to counseling. But I have to tell you, to be in a MAP program, you can refuse the counseling and still get the medication. They don't make you, but they offer it and they suggest that you do. Because some people just say, I'm working, I'm fine, if you just give me the pill, I can take it, go to work and manage my household, I don't need the counseling. That works for some people. But some people want the whole package, maybe hoping to become abstinent. So they have choices.
So have there been any data on the success rate of those being released and still on the medication?
You know, it's hard for me to get the true data because the only data I was able to get a hold of were people that were connected to OASIS programs, right? But if you didn't go to a program but just went to a doctor for buprenorphine, I don't have a way of knowing that, right? So that's the only reason why I don't put that data in my report, because it wouldn't be a true picture.
Okay, so pertaining to those being released, what are the recidivism rate for those on the medication? How is the recidivism rate still the same, or?
The recidivism rate is lower, according to the data that I picked up to do this presentation. It's lower. You have them stabilized. They're not coming out trying to rob anybody or hurt anybody to get a hold of substances. And I have to tell you, when people want the proper dosages of the medication, when they take other substances, it doesn't do anything for them. And they'll learn to stop doing that. Because sometimes they still do that. But they'll learn to stop because it won't do anything. That medication already did something to the receptors in the brain to just kind of equal them out. So hopefully, you know, that gets known. And that's it. So I thank you all for coming, especially 4 o'clock. I thank you and have a wonderful evening. Thank you.